All right, there it is. Welcome back. This is the Task Force on Affordable Accessible Healthcare, and we are moving along to our agenda. So Joshua, why don't you help us look at the accessible principles of accessible health?
Sure. Following the conversation of affordability, we want to have a conversation around accessibility, and with all the same ground rules, so there's less of talking for me to do the intro here. Please take a look at the accessible items that we put in here and think about accessible for who, accessible for what, and what's important to you that we include in scoring down the line here in a few weeks, and that we recognize amongst ourselves as important.
Jump in. I think this is bring us right back to that issue that is out there, which is workforce, because a lot of these depend on workforce as underlying for availability, timeliness, all of those things. So I have a constituent right now who has no affordability problems at all. She has no income, she's approved for all free services. He's in a lot of pain, can't sleep at night. Primary care was accessible to her immediately. They screened and said, you need to see a specialist, and we'll make the referral and get you an appointment. They've lost their last women's health clinic provider who can take appointments. They're recruiting desperately. They think maybe sometime in November, December, they'll be able to start making new appointments. That's not accessible healthcare.
So I would, I guess workforce underlies a number of these, but there might be other things that also underlie each one. For example, broadband. So I think workforce is an all-pervasive issue. There's no question about it.
So can I just, because this is a place where I'm trying to wrestle with the issues of both workforce and broadband actually helps bring it to focus as well, which is for us to think, what is it that we can put attention on here? And where do we have other initiatives in play that are trying to address some of the underlying issues or some of the key issues that also are at play? What is it that we can do as the Affordable Accessible Task Force on Healthcare? Because because we know we have broadband initiatives. I mean, we don't need to talk about broadband initiative. We have broadband initiatives all over the place, and good ones now. I mean, I think and funding for it even. Workforce, we have some workforce initiatives already underway. And I think maybe one of the questions for us is, what do we identify as what other initiatives do we currently have underway, and how does that get distinguished from what this task force can focus on that takes a new direction, or not a new direction necessarily, but it takes some additional initiatives that complement or supplement what else is underway. And ask ourselves the question, is there a workforce component of that we should also be identifying? Because workforce is so critical right now. But if we put all of our attention there, we won't have been able to put attention other places that I think seem to be critical as well. So so for me, it's trying to tease out what this task force can do and put particular attention on to move things forward that aren't happening in other initiatives.
So based on that, I will say one of the things that jumped out to me on this is the includes remote options, which I think our bodies have been really strong at expanding telehealth and telemedicine, especially during the pandemic. Yet last year, when we heard resounding testimony that allowing audio only, I'm going to get really into the weeds here, was needed. And for mental health, substance abuse, primary, for everything, because of pushback from stakeholders, in my opinion, it got watered down. And so I think, to Bill's point, there are things that we are doing that I think we need to come out even stronger on and find a way to get them done. And that would be a huge priority for me personally. Because that helps with workforce. It makes, we'd have to start looking at licensing and how we can do that across state lines. I mean, it's a big job, but if it's really that important and will help drive accessibility, why are things stand in our way?
Can I ask a question on that front? When you think about, in particular, supporting telehealth and remote access, is there a portion from your last year in session that is funded, COVID funded, that we have not only policy concerns, but funding concerns around continuation on? We know the answer to that? Okay. So Julie, can we mark that so we look for that answer?
I don't think there's,
No,
I think the
no.
initiatives we have taken are not COVID.
Not
funding.
COVID funded.
Yeah,
No.
Great, okay.
no, the ones that are, what were funded through COVID were prior iPads that are permanent, so to
Yeah.
speak.
Yep.
That's one thing we don't have to,
Yeah.
we're not standing in a hole figuring it out. That's
No,
great.
No.
Representative, do you mind? We just,
Oh,
I
sorry.
say, no, I'm just looking to Ginny. Representative Hinsdale was.
Yeah, that's what
Senator.
I'm sorry,
You know what? Either one also.
Senator. Thank you.
So I didn't even notice on a few things. One, I hope the language has changed to be more thoughtful about, instead of regardless of these identity markers, responsive to. I mean, I don't think you want care that's regardless of your sexual orientation or gender expression. I think you want it to be responsive to, and to be responsive to your language needs, responsive to your immigration status. So I don't know that that's the best practice word, because I don't want to get into like race-based care, which could, you know, that would be a red flag, but I'm just saying, like, regardless of doesn't seem to capture what access looks like when you're talking about different identities. When I hear transportation to healthcare services and remote options separately, I just wonder how far the committees have gotten around mobile care and getting, you know, that's been a huge part of care for migrant farm workers and people in rural areas in other states. I think, like, when I think of accessible healthcare, it feels like I don't know where it's captured, that people just wanted it to be easy to understand and to be able to do the right thing. And they're so worried that, like, there's no navigate, they get caught doing the wrong thing and they won't even have known what the right thing is to do. So I don't know how to put that in technical terms, but that is what I hear a lot, is people are just afraid if they don't have a magical friend in the healthcare system, they don't know where to begin and where to end.
In a lot of systems, it's called a navigator role.
I was just thinking.
Right,
in
yeah,
terms
like
of the
navigate,
navigator function,
right.
and I think there, again, I don't want us to go down the, right now, talking about options. I know that, I believe that there are some instances where trying to have additional, I think, not necessarily called navigators, but something along that line to assist people in trying to figure out how they can navigate the healthcare system and successfully with all the layers that are involved. You know, you say you make a decision, and it turns out you made a decision that put you in a hole. Whereas if you had more information at the right point in time, you would have ended up in a very different position.
Right, yeah, like informed choice.
Yeah.
But it does bring up the issue of transparency and
Yes.
understanding, I say cost, but also understanding where things are accessible. And that, I think that also underlies a lot of what we're looking at here.
And I think,
Yeah. Go ahead.
Pick up on that and say that just coming to mind is that I can't tell you how many times I've heard this conversation amongst some of us as colleagues that, well, if I, as a informed, intelligent, educated legislator cannot, or am having difficulty figuring out what it is that makes sense to do in this particular situation, or what are the reasons, let's think what it must be like for someone who is operating without all of those advantages of access to information, of access to having education. So I think there's some level of that that's very, very real in terms of accessibility. And it's not even strictly an issue of language proficiency or cultural awareness. It's broader than that even.
Right.
Well, it's even more compelling when someone is in dire straits or in pain and is sick and needs to access services. And people sometimes don't have the stamina, I would think, to access services when they're not feeling well. So,
including economic status, education status, and health status
Yeah.
mhm.
Yeah.
as part of the barriers to access.
And say that it's a situation where the last resort for people has been going to emergency rooms. And if our emergent, if what the recent trends have been are overwhelming our emergency rooms, then that becomes an immediate problem that we have to face. The example I heard about 29th, St. Albans can't take, Burlington won't take them, we can't take them. That is totally distressing for me. Maybe the answer is figure out a way to move people to more privileged care.
So it does raise the broad question also about where different types of facilities are available within the state. So we know FQACs have always been a safety net across the state. And then we know that specialty care is distributed idiosyncratically, but maybe concentrated in some places. So that does very much affect. To what extent do we want a micro plan? You know, micromanaging is something that is difficult to do in this situation. But what are the planning principles that we have to underlie accessibility?
Yeah, that's sort of the bullet one.
One of the best models I've ever seen was mobile substance abuse treatment in Lisbon, Portugal, just on your way to work, by the freeway, like wherever people needed it, it traveled around the city every day, different things. But, you know, it just, like, we need to make it convenient, roadside healthcare, you know, what's stuff.
Well, whether it's hub and spoke or whether it's mobile.
Yeah.
Just
Go ahead.
like this, about reinforcing the I know we've done a lot, but in a lot, but this is, and we have to do the initiatives we had around loan payments, scholarships, you know, go after placements in educational facilities that now can't find enough people to teach to be able to get out to do it. How do we increase that pipeline? Is that, you know, in the past, we've had initiatives around foreign workers coming. And is that an option? Is there, are we putting to work all of the people that are, for example, the nurses that do have teaching ability? Have we connected them up with the education institutions to do them? are we doing enough to increase the pipeline? I think we're now got a lot of stuff in place to catch those students that are graduating and trying to keep them here. But are we doing enough to increase the pipeline?
Well, if I may, I think I would support, I mean, I'm particularly interested in efforts that we make that can invest in Vermonters moving into that pipeline. And I think we had a good example of that last year. And I think this was related to COVID funding, but where I'm not going to get it exactly right, some other members can help me. But where we in fact had an initiative to bring the education right into the facilities and some of the long-term care facilities where people could be trained to become who are LPNs could be, or could be trained to become where people could work their way into a higher level of responsibility, but bringing the training into the site where folks are to make it much more
Yes.
acceptable
Are
possible.
we doing enough?
Exactly, but I think I agree.
Well, what are the barriers?
What
to
are the
that?
barriers to doing more of that and investing in the broader community and individuals within that community?
So I guess the question for me is, we do have a task force working on, or a group working on this now, and that we be aware of that. And as their recommendations come out, we focus on those recommendations when we bring our recommendations forward. I don't think we need to reinvent the work that they're doing. I think there are some really good ideas out there. And I know that the Vermont State College system is also working on this. There might be some things that we can do to fine tune whatever recommendations come out, or to make it more.
To be sure that we are fully knowledgeable about what is happening elsewhere, so that we're not thinking that, well, what about this? And it turns out that's happening.
I think the other key is that when we look at things, we not add to the problem, that we not create things that seem like terrific, adding to accessibility that require more people that we don't have and only take away from something else.
Right.
I mean, our committee was not at all very thrilled about the mental health initiative to have children's outreach in Rutland, not because it wasn't a terrific initiative, but because we can't staff the existing crisis response team around the state. So this was creating a new crisis response team that they were going to have to recruit for mental health workers that aren't there. So I think that's something.
And I'll give an example, but at the risk of treading on some, at the risk of establishing, giving the go ahead to establish a substance abuse treatment facility in Vermont that's going to primarily serve out-of-state folks, but who's going to draw from workforce with salaries that we can't be competitive with, and that I think we need to be smart about whether we want to. We need to be smart about that, and I know that the Green Care Board going process. I've reviewed some of that, but there are issues with we have a workforce we have in our healthcare system is a precious resource, and I'm frankly concerned that we set things up in such a way that they're going to be cherry picked to serve folks who aren't our primary.
That falls under bullet number 1. And then where are those folks coming from? How are they being served? But yeah, there's a lot. Go ahead.
A slightly different way of looking at it, and I was just talking to someone, is it what I said or what you heard? So I'm going to say this isn't what you meant to write or what I am perceiving it as. And when I read this, I see these are all aspects of helping someone once they're sick. So where is the community level supports? Where is the public health? Where is the accessibility to walking, biking, local food sources, like cooking classes, and your local rec, I mean, really basic stuff, but I think there's just, I'd love to see, as we talk about this, it's not just provider-based, it's also a public health, and if we lack the workforce in the provider base, can we offset some of that over the long term by having community-based focus, not just when someone's sick, but keep them healthy?
So I would say that as I read these, I agree. We need an SDOH bullet, a CDO bullet.
I can't hear you. Josh.
I was just saying, I would agree that missing here is an SDOH bullet, a social determinants of health
I
bullet,
think you need to not use acronyms
Yeah.
because they're not translatable. for
Yeah.
People listening.
not the mask either, even understandable. Right? What did he say? So social determinants of health bullet and a community organization bullet in some combination. That's what I'm hearing, and I agree fully.
Very much so. All right. Anything else that you'd like to add? Committee vote, task force on the accessible list?
I'd just like to say I love the last one because in surveys of my area found that obesity comes up and helping people eat better would be it's all the way.
So as I'm listening, I'm also, again, hearing that there's both long-term change, there's long-term transformative change initiatives, and there's very immediate change issues. Some things that are, what can be done now that has an impact now, but also what can we do that continues to underscore and underwrite long-term change rather than just constantly being responding to the emergency in front of us, either at the individual level or the community level, and recognizing that we probably need to put attention both places, but we're going to need to make some choices as well. And again, I come back to what is it that we can do uniquely to move things forward.
So, and that raises that the discussion about prevention is a big one. And obviously we have a chief prevention officer now in the governor's office. We have a prevention council in the Department of Health that is across the silos, across all agencies and departments. And so that's actually on the list of things for me to do once we get back into our committee structure in January, is to what's happening. And but I guess we want to encourage whatever's happening because it is a long-term, it's a long-term return on an investment that will save dollars over time. And we did some calculations a few years ago, and it would be helpful to know what those long-term returns are. The public health issue is very important, and social determinants falling into that. We can move tangentially and talk about prevention for vaping and smoking, all of those areas. I think what we want to do first is to focus on accessing the care that people need and making sure that there is a robust public health prevention program in our state. Oh, that's just my opinion.
I would just pick up something you just said, just put it briefly on the table. I'm pulled to have us notice where we've been successful. I think sometimes it's so easy to keep moving to the thing that we haven't done yet. And as you're talking about prevention, and I've been around this building long enough to know smoking reduction, tobacco use reduction, smoking reduction. We have been profoundly more successful than many people thought we would ever be. And I can remember specifically, and so we need to remember we set something in motion and we stick with it, and it makes a societal change. So even attitude changes are possible but it's just a matter of both vision and commitment over time. I remember, I can't tell you, I remember the restaurants in Heinsberg said, if you ever ban smoking in the restaurants, we'll go out of business.
Yeah.
And of course, the case of they flourished. But so we're confronted with both attitude change as well as personal change and community change. And I guess I'm mentioning it in part because it's a hopeful. I'm trying to, for myself, say there's hopeful possibilities of what we can actually impact, even in the midst of where it seems like there's a big thing in front of us to change around the healthcare issues, whether it's obesity or whether it's related issues.
Well, I think the whole area of chronic care and then moving to the blueprint has been very successful. We do see some outcomes there. But then the question is, as we're working, what role will the Department of Health play in informing us about positive outcomes?
Perhaps.
So, go ahead.
I was just gonna say, perhaps this segues into also what are principles that the federal government is looking at around affordability and access that we want to weave into our approach. I know you all wanted to maybe get into where the feasibility of all of this is discussed. Options.
Having said that, that's a good segue. So we're a little bit behind, but I'm hoping that we can get through all of this before we take a lunch break, and we might put our lunch break off just a little tiny bit, to see how it goes. So is that sufficient then for accessibility?
Yeah.
Yeah. All right, so Joshua and Julie, thank you for bringing us some options, and we'll let you go through those.
Stimulating our conversation.
Yeah.
So just a couple of heads up for this. This is, again, just to remind everyone, not recommendations. These are a list of options. They are also not a comprehensive list of options. They are a list of options. As we go forward, one of the things that I'd like folks to think about as we introduce these options are if they're ones that you're like, there's no way I can get behind that, don't need to spend a lot of time explaining it. We can just put it on the table. You don't have to say that right now, but if mark it on your sheet, right? Like, so that we can come back and focus on the things that matter, that you can get behind and support, right? Those are the things that we want to actually spend our deep dive analysis time and research time on, to bring you the information you need to understand something that you don't understand here at a future meeting, or to explore something that's not on this list that's adjacent to it, or missing completely. And those are the areas that we want to spend the majority of your consultants' time and hours, which is answering those questions that help you understand something and that help you put it in Vermont context with the information necessary to move forward during legislative session. There's
nothing here I didn't, I'm not supportive of, but there is some level of what can you get from it? What's the immediate thing that we absolutely have to pay attention to? And I hope that we can help us focus on that.
Fair enough. So as part of the scoring process, we will take into account what can be done. And every conversation that I've had, with you individually, it has come up that I want to be able to put something on the table that we can do now, will make a difference now. And so that will be in our scoring. And when we come back at the November meeting, I think would be the first expectation to set expectations. I think October will be answering questions about things and putting other things on the table still. And that when we get back to the November time, we'll be able to start giving you ranking that will say this one's at the top because of these reasons, right? And that's just to give you some foreshadowing of where we're trying to head with this.
Can I just step in? It occurs to me that something I think those of us sitting here are taking for granted as information, but not everybody has, I'm sure, is after the selection of your group as the consultant working with the task force, that Senator Lyons and I met you and developed this agenda, but we also asked, and you did, to meet with each member, contact each member of the task force who was, in addition to Senator Lyons and myself, and then you had the opportunity to have a conversation with each of them, as I understand it, with each members of the task force, either together or individually, and that has also been part of what's informing what we have in front of us today. And I think that's important for those listening to know that has taken place. That doesn't mean that there aren't things that maybe can still be added to this list and will be added to this list, but that's also helped inform this.
Yeah, I appreciate that. Thank you, Representative Lippert. We produced, the other thing I would say about this list is we haven't done the research yet on these. These are just a list of ideas that we know of and gathered in order to begin this iterative conversation. And we excluded lots of things from this list that Vermont's already doing, right? So that's the other thing I wanted to do at the outset of this conversation is just, and not to repeat what the co-chairs have said already around what we've already done in Vermont, but just to put a fine point on the breadth and depth of what Vermont has done. Vermont expanded ahead of the ACA. Let's be clear, and expanded for kids and adults with an all-payer model in Vermont. We have an ACO to help manage SDOH in Vermont. The Blueprint for Health has grown and expanded as well. You have Vital, which is the Vermont Information Technology Leaders, which is a functioning health information exchange in Vermont, an all-payer claims database that produces transparency reports in Vermont. There is an insurance rate review process in Vermont and a hospital budgeting process in Vermont. There's a cost growth target, although it doesn't have teeth, if you will, regulatory teeth. There is a cost growth. So there's a lot of building blocks, foundational blocks that are here in Vermont today. And in addition to that, and as the co-chairs have said, there have already been a number of initiatives and there are a number of ongoing items around workforce development, around education. There's been loan repayment programs. My predecessor in Medicaid actually paid for a chair in White River Junction for a dentist 25 years ago. And so we've been doing things, co-locating mental health counselors in physical health offices. And so we don't take any of that for granted when we think of what options should be on the table so that we could do something now. So be here now, focus on for who and for what, and that's what we're gonna do and try to do.
So I guess it would be helpful if you could go through this and we will hold our comments. How would you like us to respond, if at all, during your presentation, just knowing the time?
Yep. So what we'll do, and I think we can make this, we can actually do this in a number of ways. And so let me offer this option, my foggy glasses off. That's how I know I was talking too long, right? My glasses fogged up. We could do this one of two ways. We could hold us going through this and do lunch, since you're very close to that, or else it's going to take us 20 or 30 minutes to go through these without interruption, just to say what they are. I don't believe we could do it in 10 minutes. And so
We have till 12:30.
okay,
So before lunch break.
Okay, I think that's not a problem.
Okay,
That we could go through it here in the next 20 or 30 minutes. We're just going to put them on the table. So I would ask for no, for only
questions of
questions,
clarification?
for only questions around like clarify what you're talking about. I don't understand it.
Legislators are very good at finding a way in.
Yeah.
This is just for clarification. Let me tell you what I think.
I've reported to many of you previously. Okay, so we'll just start and Julie will help me because I don't have this one. Let me do it this way. So you should have in front of you this option, the one that's on the screen there, and it includes a very brief descriptions or terse descriptions, and then the option on the left-hand side. And just to orient you to the sheet, we have bucketed these options into cost containment and value-based purchasing, ACA Section 1332 waivers, state subsidies and service expansions, pharmacy, and transparency and regulation. These are not mutually exclusive buckets. Some of these could belong in more than one bucket. The titling for these buckets is not, without prejudice. We just put words that we thought would sort of encompass what's in these areas. And as we go forward here on these, just for your own information, we have split these up amongst the subject matter experts, myself, Beth, and Tim. And so some of these Tim will speak to and some I will speak to. Beth is not here, so primarily I'll speak to the ones that she was going to. Perhaps a little less information in my noggin on some of those today. With that, I'll start here on the first section, the cost containment and value-based purchasing. We've talked about this a little bit before. There are affordability boards and affordability standards. Fitting into this one would be your consultants would, for example, give you what's going on in other states, what those ranges are, what the way that they think about affordability is, and what, if anything, do they do with it once they know that it's unaffordable for certain groups or for certain people. That does require a structure to be put in place to accomplish it. So there are, things that would have to happen in order to allow that to occur. It's also, I would say, a long-term item that would fit underneath, that would help to capture a number of things going forward, but wouldn't be something that you would see immediate benefit to immediate humans from. The cost growth benchmark is one that is being done in Massachusetts and some other areas, and is one that puts a benchmark on the entire system. So not on growth in one specific component, but what's the overall growth entirely, and what should our benchmark be in the growth rate of the system, and then what do we do with that? So I, without bias, that's what it is. That's what it does.
Sorry. What does that mean?
So the idea is that the state would identify how much spending can grow for healthcare, right? And would break it down by component, right? So there's a bunch of different ways to multi-slice the component. Right? So it could be broken down by providers, right? It could be broken down by areas like long-term services and supports with all, you could break it down in different ways. But after you break it down, you're getting an aggregate number and then you're breaking it down within components and then you're addressing a target. Let's say your target is like our target for the all payer is 3.5%, right? Once you have that target, so we have a similar target to that. It's not the same, but it's similar because that's just for the waiver, right? So it's, once you have the target, then you have to figure out what to do with it. And so the point of that one, I guess, is what would we want to do with it? And would we constrain to that amount? And if we were going to constrain to that amount, what would be the protocols for that? It's a big policy issue.
I was just trying to figure out how, when the renowned care board, for example, is set in the process, you know, our growth is going to be contained within economic. How different is this than that?
So in fact, in Massachusetts, it hasn't been different than that because they have a number that they which is a topside number that they're not constraining, Medicaid to, that they're not, they're not constraining to. So the difference would be that we would, to make it worthwhile, in my opinion, we would need to constrain against that number. And that would require offsets in every legislative session, including most likely in the budget bill, right, where we would have an offset line. So you would have, if I just play this out right away, I think it would actually play out. What would happen is you would say, we're not going to grow more than 3.5%. Here's all the things you want to do. Here's the 6.5 billion we spent last time. Here's 3.5% on top of that. There's got to be an offset. Everything you put in has to have a negative in order to stay within that number. That's how your budgeting would change. If I was sort of fast forwarding to what I think would happen on the budget.
If I could also add, the other difference, Senator Westman, is that agreement, that's just hospitals.
That's hospitals.
This would be the entire system.
And if you look at Maryland's hospital regulatory process, you set percent increase. So you could do it for a sector, hospitals only, or theoretically. But
Yes.
you'd have to have the infrastructure to do that. The board would have to be different, have a different model.
I mean, we can't just say renowned care board, what you're doing now, we're just gonna add another thing.
Or two or three.
Or two or three.
It also occurs to me, the key to this is what's the definition of a state's healthcare spending? What's in, what's out? It's like, that makes a big difference in terms of how you, so anyway,
That's why you have a long term next to that one.
So I'll just remind us.
Thank you, Deb.
We're just walking through. Right?
Absolutely, with all due respect, I just remind us if we want to get to lunch.
Yeah.
We can, this discussion, we have 2 hours this afternoon for, so episodes of care across all payers. So an episode of care is a complete episode. So it's from the tip to the tail of the clinical need. But the episodes that are most impactful actually don't constrain to the clinical need, but expand to the social determinant of health need and expand across. So labor and delivery or a maternal pregnancy episode. In fact, when they first started, they were episodes. This is just, for example, we're just for the hospital labor and delivery, right? Maternal care episodes have expanded significantly. And if you think about how most to impact accessibility and affordability, you want those big chunky episodes that include everything. So for a mom and a baby, it would be from when mom decides she wants to become pregnant until the baby turns 1. That would be my recommendation on that specific episode. Each episode, you would do this in different ways. When you do it, you define not what Blue Cross Blue Shield will pay to each provider, but you require all of the pieces to be included in the episode, and to make a prospective payment to one provider who manages the entire amount of care for that time. You can do it for chronic care. There's asthma episodes that are year-long episodes. You can do it for SUD, OUD. So you can do it for complex areas where all of these things have actually been done in other places today. Sort of the easiest ones to do are like a hip and knee or something like that. Those are actually have they have a lot of impact on Medicare and not near as much impact on anybody else. Those sort of heavy duty surgical episodes with follow-ups. So this is on here as one to consider, not for Medicaid alone, but for all payers. So this is powerful when you require episodes across all payers in your system, and allow them to negotiate prices and all the things they would with their network, but require the episode to be definitionally the same across all payers. Because then you're dealing with equity there as well. There's so many things you deal with when you do that. And the only elephant in the tent that will have trouble with is our ERISA plans, which is, I know, still an elephant in the tent.
Well, and I want to just use this as a clarifying opportunity that is very important at some point that we look at who we can impact and who we can't impact with our decisions, so that as we make these decisions along the way, there's some very helpful charts that are very revealing in terms of where Vermont, the legislature can have an impact, where we can't. Aware of that.
I thought you were going to say the elephant in the room, and just so, because I'm noting drawbacks as I go on this, but I would imagine with fee for service, we're worried about people being overserved with care. And with this kind of model, we're worrying about people being underserved and getting less care.
It is correct that when you implement an episode, there's a number of different ways to implement it, and that certainly this afternoon and on an ongoing basis, we can discuss those different ways. There's ways to manage that underutilization by episode definition.
And equity is for us to,
Now we're going to continue.
yes.
So
No discussion.
the health insurance rate review, I mentioned the Rhode Island process, and we'll use that one as an example. And in particular, Beth and Michael, who works with regularly at Baylor, they have been working with the insurance commissioner in Rhode Island for a very long time and helped develop this initiative. So it is another rate review process, and we can get into the detail on that, and how successful and unsuccessful, the drawbacks and benefits are. I'm going to turn to the ACA Section 1332 waiver portion and turn it to my colleague Tim on the phone to walk through these with you.
Sure. So each of these, can you guys hear me okay? You can. Each of these three options takes advantage of authority under the Affordable Care Act as part of the marketplace generally, to grant waivers to the way the marketplace is administered. And through those waivers, they're called 1332 waivers because that's the section of the law in which they're enacted. And through those waivers, the state would be able to recapture some savings that would otherwise have been going to beneficiaries or to individuals in that state through premium tax credit subsidies and whatnot. And so they're very powerful in that you can structure them in a way that's going to help the state move forward, and the state can reclaim some of those savings if they need certain guardrails set up by the statute and instrument statements. So the first would be to think more broadly about a public option, right? And I think this is a colloquialism that we've all used in terms of thinking about creating an insurance option for beneficiaries in the state that's not single payer, but is a public option available to folks who may otherwise not qualify for premium subsidies or tax credit subsidies in the marketplace, but we would be able to provide it through some sort of public plan. States have begun moving in this direction. Washington State, the others, Nevada, have begun thinking about ways to implement a public option using state-only funds and using funds provided within the state. There is an opportunity here, although the administration hasn't clearly articulated how they're going to use 1332 in this regard, to leverage the waiver authority in addition to whatever the state may want to provide, to create a public option and to create wider access through insurance using that authority. It is a bit unknown. It's interesting. We were talking a little bit before about sort of the advances that Vermont has made, right? And to take those into consideration as you think about what you're going to do next. I can just say from a federal perspective, Vermont has always been viewed as a leader in many of these regards with respect to what they're doing with insurance generally and healthcare more specifically. And so this could be one of those places where if Vermont wanted to think about ways to uniquely leverage an authority that nobody else has kind of done yet, it would certainly be within that vein. The next option is the insurance option, and this, quite frankly, is where nearly every waiver that has been approved under 1332 has been approved for a reinsurance program. And it's basically an option where we create what I think of as almost stopgap insurance for particularly high cost individuals who kind of blow through the normal costs that they would see in insurance, and they get reinsured through this mechanism. So you can think about people who, achieve certain cost limits or hit certain attachment points. The state would then reimburse insurers for a certain percentage, and it varies all over the map, anywhere from 60% to 100% of the costs associated with those individuals directly back to the insurers that are covering them. And it's a way to keep premiums down for everybody because those high cost individuals are reimbursed for those costs, and do that in a way recouping these, as I said before, these pass-through payments. The payments from the federal government are what is used to finance the reinsurance pool for all the folks in the marketplace. And then the last one here on the page is something called an adjusted plan option. And the way I would characterize this is to kind of leverage the authorities in the Affordable Care Act to create plan options that are they're not qualified health plans in the way that we think about qualified health plans in the marketplace, with all 10 essential health benefits, meeting all the requirements of the marketplace rules that have been set down by CMS, but would serve, to create a particular problem or a particular gap in state coverage using this authority, right? And so whether it's targeting it to unique sets of populations or services that are hard to cover, or individuals that are hard to cover, different markets, small group markets, it would kind of waive those, what some would say as our restrictive marketplace rules for QHPs, create plan options that would be, as I say, more tailored to what might be needed in the state. The only caveat I would kind of articulate here is, as I said before, the Biden administration has not been crystal clear yet as to how they're going to leverage 1332 authority and what they're going to want to see and what they're not going to want to see. These sets of options were developed and promulgated under a prior administration, sort of taking an expansive view about the flexibilities under the Affordable Care Act. Not entirely clear to me that the Biden administration would kind of go as far as some of these other options would articulate. So I just throw that as a word of caution in terms of where they may be, in particular on this adjusted plan options.
Thanks. Applying questions on 1332 waiver options. It's an area where there's particularly opportunities between the state and federal government to support some areas.
Can I just, I'm assuming that you're going to, one of the things we're looking for you to do is to continue to look at what other federal possibilities might be emerging in the Biden administration.
So I was saving that for discussion later. But you can ask it.
No, I'm just saying.
The quick answer is yes.
That's a given.
Yeah. No, true.
The quick answer is yes, and we're actually I'm gonna speak to some of wherever the appropriate point in explaining some of these are, where we already know there's some options. Or we anticipate there will be some options, or we hope there's going to be some options. So we'll let you know in each instance. Moving to state subsidies and service expansion. Remote access to healthcare services. So we've discussed this earlier today. There's nothing magical here. What we would consider as part of this for the committee is to, if there are areas where we have those gaps or we want to expand, if we want to look at, state law or state options there to support that, then that, is an area that the fewer gaps there are there, the more valuable it is, really. The closer we can get to 100% of people having access to the service, and for 100% of services to be accessible that way, the closer you get to both of those things, it's not additive, it's a multiplier, actually, as you go from half of everyone to 90% of everyone. It's a big deal. Premium and cost sharing subsidies. So Tim, did you want to speak to this one? Sorry, see your name on it.
You're good. You're good.
The premium and cost sharing subsidies. Okay, I'll just do it. So the simple idea here is that we could offer additional subsidies to individuals, and how we pay for those depends on the individual we're offering them to. But those, when you think about closing out of pocket gaps or supporting expense premiums, those that direct cash to those individuals or subsidies to buy those things is one way to go. Health equity, expand the Vermont Blueprint for Health, community teams, including mental health and maternal health. And I'm going to let Julie speak to this one because I know you're passionate about it.
I do support the Blueprint for Health and another contract. And so I just think it's an opportunity in terms of, particularly in terms of health equity, because as you know, the Blueprint for Health, those services that are provided are generally provided regardless of insurance. So people don't have to, fill out forms and be verified. They just get services that their providers they need. So that's an opportunity to beef up that in terms of health equity, to beef that up. And what we found, one area that I support in particular is the Women's Health Initiative, which is part of the Blueprint for Health. And that's been successful in increasing screening for social determinants of health and referral to services. And what's been found, that particular program was launched in 2017 because of a legislative concern around pregnancy intention. They wanted to increase the rates of pregnancy intention in Vermont, and that's been successful. And that's to the extent that we can measure it, which is difficult, but anyway. But what we're finding is that there's a need in OB for pregnant women. So like there's specialty practices that serve OB/GYN, and the GYN side is what this is focused on with the existing Women's Health Initiative programs. It's focused on, but we're finding that there's a real need in the OB side for that mental health, social work, kind of coordination of care services. Not surprising, especially in the last couple of years. So this is an opportunity to reach out and to improve outcomes for pregnant women, newborns, address the need for increased mental health services, and also kind of make it equitable in that it's just kind of a utility that's provided by the state, paid for, you decide who pays for it, I guess. But perhaps paid for by all payers and then available to everyone who needs it, their, the primary or specialty care provider.
So I would just, thanks, Julie. I would just underline on that one that think about it, not just maternal as an example, but that mental health as an example, but that the blueprint from an insurance perspective is a way for us to be equitable in the distribution of resource, because all insurers support the staff in the blueprint, right? And people are not limited in the way they would be through their single insurance card and using those resources that the regional blueprint teams have available to them, the humans. That is one form of equity, one way to assure a certain type of equity in the market. Okay. So it could be a utility player on the equity front. Is how I would think about it. Using the sports reference, the only one I will use today. Okay. I was wondering about that. So the next is services for pre-duals, and the concept here is that there are individuals, and we've come a long way. So we've come a long way in being able to identify these individuals prospectively. So that's one thing to keep in mind. A long way in the last 5 years, a very long way. So identifying individuals across all payers in Vermont, so across residents that we know of, right? And who are likely to have multiple chronic conditions to become dually eligible in the future for Medicaid and Medicare, both because of their economic status as well as their clinical needs over time. The most expensive population that we have is individuals with intellectual and developmental disabilities. The second most expensive population are seniors with co-occurring conditions, including mental health in many cases, or substance abuse and other chronic conditions. And the vast majority of individuals with all of those co-occurring things become dually eligible. So there's a pathway here, remember, like for individuals don't all sit in place, but if we can identify dually eligibles, people who are likely to become dually eligible, doesn't mean they will, but that they're likely to, we can provide a light HCBS, so a light home and community-based services, series of supports for those individuals, and including, in this case, a medical home, primary care physician, mental health counselor, whatever those things are that we think will prevent going forward. And the key is that it would delay or prevent those individuals from becoming dually eligible. The reason this is important is because it's an equity, it provides equity to individuals by identifying them early and providing interventions to help them be better in the future. And it also is a massive, on the affordability side of this thing, it's a massive increase in the ability for individuals not to have those half-gallon of milk issues turn into, I can't go to the emergency room, or I can't help my kid, or whatever I want to do with my life. And so that's why this one is on here. And honestly, this one is on here also because on the side of this that is not the household side, but the state funded side, we believe that the Biden administration will fight on this, that the Biden administration will want to support this. And that's just not a belief. We understand from our experience and conversations. So
Will not.
they will want to.
Oh,
They will want. They will. They
Thank
will
you.
want to.
I heard will not instead of will want. I thought, what?
Yeah, there is a pathway here.
Discussion.
Thank you.
Right?
So When we get to the afternoon, we can talk more about that, but, so that's one. Tim, can you speak to the next one?
Sure. So I think it's fair to say that under the Recovery Act, the rescue plan that was enacted earlier in the year, the enhanced subsidies, both for uninsured and for Affordable Care Act coverage, have, been incredibly helpful for states, not just Vermont, but all states in their insurance markets. And so I think Vermont's not going to be alone in wanting these enhanced subsidies to continue beyond 2022, which is when they're scheduled to expire in the current law. And this would be, in particular, if this revenue were still in the system, as you were thinking about a 1332 waiver or another marketplace option, having those revenues in the system would be helpful. And so I think it's fair to say you would be joining other state legislators and other states in asking the Biden administration and being incredibly clear with Congress and the Biden administration to continue these subsidies, the enhanced subsidies for the benefit of the markets, not just in Vermont, as I said.
Thanks. The next one is expanding Medicaid to additional income levels and certain ages. And this one came out of discussions that the legislature had, I believe, this year, and is on here because we believe that's an important one to continue and to keep on the table and to discuss. I will say at the outset of this discussion that your consultants would need some guidance on this, in particular around the Medicaid expansion coverage that we're looking for between on an age basis. Some clarifying discussion around that would be helpful. So that's on there. Moving to pharmacy. At the outset on pharmacy, I want to say that we could spend a lot of time on pharmacy. Pharmacy has grown from a very small expenditure overall over the last 20 years to a very large expenditure in the healthcare system with continued growth. It also has had tremendous benefits to the population. And so I don't want to just talk about how expensive it is, but also how beneficial it has been in many areas. And many, perhaps all of us here have COVID vaccines, and that is a testament to the pharmacy industry's ability to do some things that are very good. So with that, the other thing I want to mention about pharmacy is that the biggest issue, around the biggest issues around pharmacy, in fact, are largely out of state control and sit in the federal government's hands. And although we could wail and scream about those issues and appropriately be frustrated by some of them, they're not things to the what we can do now. So the things we've put on this list are things that we believe, at least we could do now. So pharmacy and cost sharing limits and reductions. So limits to sharing in the commercial market is within your power to control those requirements, should you wish to, and providing cost sharing reductions to all the public plans here in the state is also within your power. Fines for unsupported price increases. So this is one Nashby, I think, did the paper on this. Actually has a draft state law on it that we could avail ourselves of, and so unsupported price increases. There is some precedent for moving forward on that. And then legislation directed at pharmacy benefit managers. No, you don't have to go back very long to there's some, Blue Cross has presented on this issue to this body, not to this group, because, but a couple of years ago made the rounds presenting on these issues. Your Medicaid division has its own PBM, as you know, and so, but there are things that can be done in PBM, to you have regulatory authority over the PBMs that operate within the state. And so that is an area we can look at for transparency, for how they actually pass through and negotiate things. Transparency and regulation. So this one, legislation on hospital consolidation, it is an area that has been discussed largely in much larger states where it became an issue sooner and continues to press on the question of not monopoly power, but in significant negotiating power that's detrimental to pricing for consumers. And so since this is an affordability and accessibility, it belongs on here for consideration. Legislation to prohibit anti-competitive contracting in a similar fashion. There are things that are within your control as far as what competition means and what level of competition needs to be preserved within the state in the healthcare arena specifically. Community benefits, reporting and charity requirements. This is, did we pass that one already? So community benefits reporting and charity care requirements, pardon me on that one. So this is, all of our hospitals are not for profit, and how they report what they do and how we track what they do and determine, not just what level, but how it fits into how we manage equity in our communities and how we manage diversity in our communities and how we manage those other things that are now important, and perhaps some of those reporting provisions and requirements around that should be updated to align with priorities that the ACO has, for example, in communities, and that the blueprint has within those communities. Not to say that they aren't in some cases, but there's opportunity there. So Tim, can you speak to the consumer focused price data?
Well, again, here, in the prior administration, and then again, under the Biden administration, the federal government has, created requirements in particular for facilities to maintain and make available price data for the purposes of helping consumers and others understand what it is they're purchasing, right? So if you believe that consumers and individuals having information about what things cost and what hospitals are charging, that will drive changes in the system, hopefully to the betterment of the system to keep costs down. It's also the case, as I'm sure you may have read, that implementation and enforcement and compliance has been somewhat spotty. And I think there's room here to create, for the state to, on its own, try and aggregate and understand and make available the data that these facilities are already supposed to be publishing. In other words, scrape it and aggregate it on their own and provide that information in a useful way to consumers and others in the market in a way that's envisioned by the federal regulations to provide that information in a transparent and readable way. Again, you need to believe and subscribe to the notion that making that information available is going to drive change. I think the fact that some hospitals have made it as hard as possible for consumers to find that information speaks to that in fact will drive some change. So I think, again, this is leveraging what the federal government has already kind of put out there in a way for the state to step in and provide kind of a leadership role in making that data available.
And then the last one, only be a few minutes late for lunch here, which is great, is reducing use of low-value services. And we have an example here, the choosingwisely.org, which has been implemented in a number of states, that helps folks decide, if what they're looking for really is supported by the evidence and not duplicative and, and helps consumers make those decisions around that. And we could do that, using our own state resources, like our blueprint teams could stand up something similar to it. We could work with choosing wisely to implement it in Vermont. It's another way to empower consumers. Think of it as a consumer empowerment initiative in a complicated healthcare sphere. It also fits into some of that navigation discussion that we had earlier. So with that, that's the first list. And I appreciate your restraint in the questioning. We have a couple hours for that this afternoon. Thank you.
Thank you. That's extremely helpful. And we'll look forward to discussing all of these this afternoon. But just to reiterate something that Representative Lippert said, and put it in a different context, there are a number of these issues, not just those that are listed as ACA, but a number of issues that fall under the federal umbrella, possibilities under the federal umbrella. Just keep that in mind.
Yeah, both important, I think both important for us to understand what's outside of our purview because they're federally, it's going to require federal action and we're not going to be able to, we might be able to encourage it, but we're not going to control that. But also what is in fact the federal government might be facilitating that creates opportunities for us at the state level.
Okay, so we're back at what time? 1:30. 1:30. So we have an hour, not quite for lunch. Okay.